So today we're going to start going over non-traumatic musculoskeletal disorders. This is all technically a little bit of medical, a little bit of trauma, and ends up getting dropped into our advanced medical section. You'll notice throughout advanced medical, there's a few extra things that we end up putting into this class that we didn't quite have time to get to in one of the others, and then a lot of extra interesting things as far as advanced medical issues that can happen. So the first chapter that we're going to look over will be this non-traumatic musculoskeletal disorders, and this incorporates everything from weird genetic issues that people can have, uh, autoimmune issues such as rheumatoid arthritis or regular arthritis as it just kind of happens as people get older. And then we'll also look at some other things that are a little bit traumatic in nature, but not necessarily full on trauma, such as sprains, strains, things like that that happen during a sporting injury or just running or doing whatever else. So with that being said, we'll go ahead and start. So once again, in the beginning of most of these chapters, try and take a look at some of our anatomy and physiology involved. As one would imagine, with a title such as musculoskeletal, we'll be looking a lot into the muscles, skeletal system, as well as how the skeletal system works within this, to include ligaments, tendons, which are all connective tissue, and kind of move on from there. So the skeletal system is basically a very bony structure that provides a couple different things. It provides that structure and support throughout our entire body, and then it also provides articulating surfaces which the muscles will pull and contract and allow movement, and it's not possible without the bones and the connection on there, and that's what it's talking about with these articulating surfaces. The average body, well, the average body is going to be less than 206 because people end up missing bones because they lose legs, things like that. Being said, the body should contain 206 bones divided into two separate categories: our axial skeleton, which is our skull, hyoid bone, which is really not is the only bone that's not connected or articulates with any other bone, and that's going to be right where airway area begins, up in the larynx. The other parts of axial skeleton include the vertebral column and the thoracic cage. Our appendicular skeletal is basically everything else, and that's our limbs, pelvic girdle. Pelvic girdle has a bit of the axial as well when the spine comes down into it, and as does the shoulder when we talk about the collarbones. So, but the axial does contain not only basically the thoracic cage, which is our scapula, also contains the clavicles, which are a little bit of both. It's considered appendicular, but also a little bit be considered axial as well. It's just one of those areas because it contains a girdle and kind of is that area that connects to the axial, and very much like our pelvis, that it can have a little bit of both on there. Continue to go over the skeletal system. We have our joints, which connect bones and classified in three major classes. So the joints are either fibers, where two bones have little or no movement, joined by fibrous tissue. Cartilaginous units of two bones by means of hyaline cartilage and fiber cartilage, slightly movable. And then synovial, which is synovial fluid allows for movement. Most joints that unite the bones, the appendicular system, are synovial. So our big synovial joints are going to be our basically everything on our appendicular system, more or less. Basically, it's big example: elbows, shoulders, knees, hips, anywhere where we have that motion, a lot of motion. It has extra lubricating fluid in there, like the synovial fluid, which allows that movement to happen very easily. Cartilaginous joints, not nearly as much, but hyaline cartilage and the fiber cartilage, a little bit movable, not a ton. And then the fibrous is basically where we get those kind of fused joints that happen such in our skull, pelvis, and other areas like that. And an example of cartilaginous joint would be where the ribs, where they connect from the cartilage that connects from our sternum to the ribs. There's some cartilage in our nose. There's a couple other areas. It's not as common, or we don't think about it as much. And there's a little bit of movement involved, but very little. So those are a couple examples all around. Looking up here, our another area cartilage is our airway, and then there's some pubis down there. As you can see, there's not a ton in there. We can see where most of these cartilage joints are including the spine. So like there's movement there, just not a ton compared to where our joints are. We have these synovials. Quick review of the overall skeletal system. So you can see axial, including our skull, spine, down into our sacrum and coccyx. And this is where the pelvic girdle, which is technically appendicular, does have portions of the spine of the axial system with that, as does the clavicles, which are it's a little bit of both because it does connect the girdle or the shoulder girdle to our thoracic cage, but technically the thoracic cage is axial as well. So we can see there's a couple that live in both sides, but overall there's a bit of separation. And then we're going to continue on. We should know these bones relatively well all the way throughout. I wouldn't be as nearly concerned about knowing individual metacarpals or metatarsals. Musculoskeletal, or the muscular system, it's actually responsible for the execution of movement and postural maintenance. The musculoskeletal system works very in tune with each other. Like I kind of said in the past, you have the muscles pulling on, but muscles just pulling together doesn't do anything. So where they connect to the bones on those articulating surfaces, that's what causes our overall movements, and the different muscles cause us to move. When that also happens, another thing that's very interesting with like the skeletal structure is that the more the skeleton gets used or more stress upon it, it starts to build up more mass. So these very strong people, or you start building lifting more, and your bones become stronger because the muscles are pulling on those articulating surfaces, which causes the bones to slowly start growing and building more structure for the muscles to pull on. The muscles are attached to bones by tendons, and ligaments are connect bone to bone or bone to cartilage, and kind of that's how those are where the connection is. The muscles themselves connect to the tendons, which then connect to those articulating surfaces on the bones. And the musculoskeletal system by itself is one of the biggest uses of glucose and energy in general. So oxygen and glucose and everything all put together. So when all this happens, but when you're at rest, they don't use very much energy. However, when movement, that's when all of our oxygen and all of our muscles will use all the oxygen and glucose, and so it becomes when in full motion and movement and strain. That's when our skeletal muscles by far bypass our total energy use of our normal caloric intake. So that's why it's good to get around and start moving. Also, just help keeping our posture. Skeleton helps us maintain, adds the support underneath, and the muscles keep us upright and with good posture. So as we go through this, we'll look at the extremities, the spine, vascular system, the motor system. Findings may include, when we're doing an assessment of this, pain, tenderness, abnormal or loss of movement, or any type of circulatory changes. Stuff that could causing a pain, big one. If there's any type of deformity, something to note. And whether, if they have any loss of movement, whether it's due to a nerve type issue where they're not able to move itself, or sometimes it can be a disconnect of like a torn ligament or tendon, which will, because that muscle is no longer able to pull on that articulating surfaces, it will have them not be able to move that a certain way. And so injuries to ligaments and tendons can have that lack of movement as well. Sometimes you'll see a deformity along with that. Sometimes you won't. Sometimes when that muscle is contracting, then it can snap off. It'll curl up around there. Seen and heard of it with the Achilles tendon. All of a sudden it snaps on the back, extremely painful, and it almost like curls up because their calf muscle is pretty dang strong. It'll curl up and then it'll that muscle will contract on itself, but because it's not able to pull on the bottom ankle or foot, it just kind of curls up into a ball. Really very, very painful. Extremity evaluation, looking at our hands, wrists, make sure everything looks normal. Good question to always ask, is this normal for you? To see if there is a other way to look at it, to see if it is equal to the other side. Sometimes they can both be messed up, but that's a decent one to try and check with, just trying to make sure they're there. Palpate on the elbows on both flex and extended. If there's an actual elbow injury, if you guys remember from trauma, we don't want to actually move that elbow. We want to keep it nice and splinted if there's an injury there. Shoulders, check for structural integrity. I don't know why the integrity of the iliac symphysis pubis is on this, but make sure it's all there. Knees, kind of the same as the elbows, ankles, feet, look for the same. Make sure everything's aligned with each other. There's some people out there with weird angled shaped toes, missing toes, everything like that. So just try and get, if it seems abnormal, try and ask, just make sure that it is abnormal for them. The spine, make sure the cervical, thoracic, and lumbar curves are pretty normal. There's a bit of a curve to our spine in general, but it shouldn't be any crazy forward, back, whether it's lordosis, kyphosis, or scoliosis. So remember, scoliosis is kind of that lateral bend down. In school, teachers should always check people for that. Just check for abnormal curvature, and then also look for signs of injury, swelling, discoloration, anything like that. For our vascular examination, we're going to assess our extremities for color, texture, arterial insufficiency, making sure that we're getting good circulation, that we have pulses where pulses should be. Lymph nodes should not be swollen or tender. If they are, but they're sick recently, all right, that's something to note. Not anything that we're going to do crazy, but if we have swollen lymph nodes all over, it can be signs of a number of different things going on, typically fighting an infection, but different types of cancers can also spread through the lymph system. So we'll kind of look at there. Also look for signs of pale or cyanotic skin. If it's isolated to a local area being pale, there's usually a lack of circulation to that area. Get cold as the touch, and then also looking for any type of pitting edema, which shows that there's spacing of fluid. Motor examination, if they're able to move, observe while they're moving and at rest to see if there's any changes. Examples of this, be like, hey, are you able to walk? Go ahead and take a few steps. Let me check your gait, see if it's normal. If they have that kind of abnormal gait, something to take of note. If there's an injury related with the ankle, like, oh, cool, there's something else there, as an example. So just try it and see how their overall movement is And then what it also looks like at rest. Go ahead and we can assess for agility, how they're able to move in general, flexing, extension, and abduction. Evaluate coordination by assessing the gait and the point-to-point movements. And they should be responsive to sensations such as vibration, pain, vibration, and touch. Remember, they might, if they're missy, if they can feel pain but they can't feel vibration, or you can touch that kind of light but kind of deep touch but they don't feel tickling, that weird light touch. All these are different nerve endings that run up and down the spinal column in kind of different areas. So if we have some type of injury where there's some type of spinal swelling, some other type of ischemia within the spine, lesion, that weird isolated one thing that's missing can be associated with that, or it can be a damage to just one of the nerves as it leaves the spine out into whatever limb or extremity that we're checking for movement or wherever else we're checking. Scene size up, safety. Look for both pharmacological and non-pharmacological. So positioning the patient in splinting if needed, positioning the arm, leg, whatever else into a position of comfort. Sometimes just a pillow underneath the arm works very well. Transport considerations for that, just make sure you take them to where they should go or need to go if there's trauma involved there. If you know if it sounds like there's something neuro, let's make sure we're going to a place that has good neuro communication. If it's something with the arm, particularly if you guys remember the elbow, we don't really want it because that joint and all this, like our knees and elbows, they have so much circulation, nerves, and everything going through there. So if there's swelling on there, it can almost cause like compartment syndrome like issues where it disallows either nerve transmissions or arterial blood flow, and venous on the way back, but important on the arterial side, get in there. And so if we sometimes we just need to immobilize as best as possible, and we don't really want to cause extra movement if there's a lack of movement there in the first place. Analgesics are great. Go ahead and give them to your patients, whether it's opiate based or Tylenol. Sometimes a little bit of both is good, and provide gentle transport. UK providers. All right. One of the first things we're going to look at, osteomyelitis. It's acute chronic bone infection caused by microbial agents. And some of the big ones involve people who have undergone recent orthopedic surgeries, kind of makes some sense. Older adults, IV drug abusers, because they're constantly sticking typically dirty needles within themselves, it's not a big leap to move from the circulatory system of some type of infectious pathogen getting in and then moving into the bone underneath, or they can go too deep, nick a bone, and now we have that infection directly into the bone structure itself. People with sickle cell diabetes, compromised immune systems, hemodialysis, anywhere there. Remember that blood is a connective tissue, so just kind of if it's the infection gets on the blood, it's very easy for that infection to move into the bones, which is where we get that osteomyelitis. Symptoms: fever, chills, swelling, warmth in the affected area, excessive sweating. We're not going to confirm this. They're going to have to confirm it in the field with some blood tests, things like that. They can needle aspirate the bone and do a bone biopsy, radiography, MRI, CT, bone scans. There's a number of things they can all do. We're not going to do much. They're going to do a bunch of antibiotics, possibly get a drainage, Lancet thing, immobilization would infect bone, surgeries, and if worse comes to worse, amputation. You see some of these depending on what the situation is, and you can definitely get some of that amputation. Or in the case of when we were overseas, we'd get some of these guys that would get blown up. One of my buddies, he lost both of his legs, and the infection got into his bone. So his amputation started above the knee, closer to the knee, and because the bone itself kept getting infected and causing him to go septic, they ended up cutting higher and higher and just having to amputate his leg higher and higher till it got about 2/3 or so up. And so he only has about a third of each leg left, of his thigh left. So ended up losing more, and that was from the aftercare. That streets of Iraq were really, really nasty, and one of the things medics that we used, if we had a handful of antibiotics, if they're able to swallow those, we would get those on board as soon as possible, because these infections, and once it gets into the bone, can be very difficult to deal with. Right, bone tumors. When we deal with tumors in general, we have the benign and we have the malignant. Benign is just kind of some type of growth within there, but it's not growing necessarily, and it's just kind of there. Malignant is where we talk about cancer, and it's starting to spread throughout and malignant and start moving to different parts of the body. Typically, it moves via the blood and lymphatic system. Usually needs that circulatory system to move about, and once it's in there, it causes all the issues. Which is why we see when we have like a mastectomy, when they end up removing the breast tissue from many of the patients that have breast cancer, they will actually take a lot of the lymph nodes out that are in not only the breast tissue, but then also in the upper arm and around that. And so they have an inability to really move some of that lymph back, which is why we don't put blood pressures on patients that have had mastectomies. If it's a double mastectomy, we kind of got to do what we got to do, but we try not to. Even a leg would work probably a little bit better. But just one of those things where we don't want to cause that backup of fluid and think that they have a hard enough time getting some of that stuff back. Primary bone tumors, multiple myeloma, malignant tumor of bone marrow, osteosarcoma, typically around the knee or femur, Ewing sarcoma in upper lower legs, pelvis, upper wing, upper arms, and ribs. And cholangiocarcinoma occurs in the hip and pelvis. Typically, we don't have to know a ton about the tumors themselves. They're typically not an acute problem. They're usually more of a long-term issue. However, we can deal with people who either know or haven't quite found out yet. It's always fun when you go to do an IFT, going to transfer a patient, and the doc hasn't told them that they have cancer, but you're now bringing them to a hospital to get seen by a doctor that specializes. And so, I've had it on accident where you ask them how long have they had the cancer, and they like, what cancer? Very awkward. Think Sunrise or whichever hospital does that. I've had it happen a couple times, and they docs mean to get to it busy, or they're trying to let the primary care, whoever else, kind of deal with that, but they find it they'll come in for arm pain and all of a sudden find a tumor. So it's always awkward there. But typically we don't deal with this in the acute setting where it's a ton. So our knowledge on a lot of the cancerous growth, we need to have some general knowledge of it, but we don't necessarily need to be specialists in this area. As we look at the skull, we should not be having that many different. We look at x-rays at any time. Sometimes we can just go, oh, that looks really abnormal. I've showed you guys enough different types of x-rays. When we look at bones typically are white on our standard x-ray or CT. And when there's not, it's usually due to a lack of either there's some type of fluid in there, depending, or it's just air. And either way, you have this, or this is just a different type of growth within that bone, which is causing it to show up different on the x-ray. And so you just see it looks almost like Swiss cheese. This person's not having a great day or end of life. This shows that multiple myeloma of the skull and punched out bone lesions filled with a soft tumor. So it's just a different type of kind of tissue in there that doesn't show up the same as a normal bone on an x-ray. Signs and symptoms: dull, achy pain in the area of the tumor. Benign tumors may or may not require treatment. Sometimes they just leave them there. Sometimes they'll surgically remove them or try and give them chemo or radiation treatments. Malignant tumors require medication or surgical removals if possible. Sometimes due to location, particularly in the brain, they can't do surgical procedures, so they kind of left as it is. There's all types of new cancer medications coming out. I don't know all of them or any of them really. It's not something that we necessarily deal with. There's just a number of treatments there, and we might be involved in transporting one of these patients either from home back to a hospital. If you are transporting a patient and they're requesting to go across town because that's where their cancer doc is, please take them to that place unless they're dying immediately. I know sometimes they're a pain in the butt to drive all the way across town, but these people need to go to where their doc is at. Lower back pain. All right, so kind of off the cancer stuff. We're going to move to both acute and chronic types of lower back pain. If you ever had any type of lower back pain, it is debilitating. Whether we tweak it, Lifting, doing all that. Luckily, these days, EMS is really trying to address this. Whether it's the private companies deciding that they're tired of paying workman's comp and all these from our back tweaks, which we've done, because this is an issue where lifting, pulling, twisting, doing things that we shouldn't, and causes that strain. If you had happened to you, keep doing what you're doing and try not to mess up your back. You can't move, you can't do hardly anything. It's excruciatingly painful just because it hurts so much. But in the acute phase, we're talking about a couple days to a few weeks, and caused by trauma to the lower back, whether that is lifting, pulling, or actually like direct trauma, getting hit with a baseball bat, something like that. It can be by arthritis or other degenerative joint diseases. Chronic persists for 3 months or more and can be progressive and debilitating. Some of these people, poor people, it's really hard to describe how much pain they're in all the time. If you've even had like tweaked your back once, you understand that it can be how debilitating it can be. So like have a little bit of compassion, even if they are on some high dose meds. See if we can help them with what we can. And it's pretty miserable. Sometimes I'll get spinal fusions or they'll look at different types of physical therapy, a number of things. So try and help them as much as we can. A couple different types. So here's our typical spinal column. We're not worried about the actual spinal cord itself, but we look in here, we have these cartilaginous discs in here and the ligaments that are involved all in between here. So we do have some movement within our spine, as we can kind of tell, allows us to bend and all that, but it's relatively stable and it's very protective of our spinal cord because we lose that, we know we're in a bad day. Just a decent picture of understanding kind of what's going on here and the different pull, strain, any type of ligament issue all in here. We can see how that can cause that, or we can see some of these discs where they have a bulging discs. Yeah, I have it on the next slide, so we'll look at it then. Talking about this bulging disc, right? So we have the nerve. This is our spinal cord itself in here in the middle. If you guys remember from spinal nerve trauma, we have this in here, all the different parts of depending where the nerve is at within the spine, kind of goes out. We have our ventral and dorsal nerve groups, all kind of going out to the different parts of the body. And we're looking at whether this is thoracic, lumbar, or cervical, even though the spinal column and the individual spinal disc will be a little bit different shaped. It's still relatively the same overall. We tend to see in the lower back though, because it says lumbar, which is the lumbar spinal process. What we're doing here, our spinal disc, and because we have more articulation in our spine as far as our lower lumbar area, and it's kind of that point of a lot of movement. This is where we'll get these strains from. Once again, the cervical spine, we do got a lot of movement there as well. Our thoracic's pretty solid, not moving a ton, right? But this is where that bulge, a normal disc sitting here in the middle, and that bulging disc comes out and it puts pressure on the nerve root coming out, and it can cause weird nerve issues there where all of a sudden they're not able to move whatever nerve it's hitting at, depending on L1, L2, L3, L4, anywhere in there, and that's where it'll cause some of those issues. So looking at that, we can see what a herniated disc is and why that can cause so much pain on there. And comes from a high risk factor, lack of exercise, low back pain, numbness, weakness in lower extremities, deep pain in muscle. And we can actually kind of tell if we know or at least familiar with our myodermatomes, if we're having a lack of movement and feeling, or any of our CSMs within, well, I guess just our sensory or motor within different parts of the leg, and or lower torso, kind of figure out what herniated disc is, or what disc is herniated on the spine. So quad equina syndrome, if you remember quad equina, it starts right below right about L2, L3, and it's kind of where the spinal cord ceases to be the spinal cord itself. It still has a ton of nerves going through the spinal column, and they all come out, but it's no longer that full-on cord. And the quad equina is the horse's tail. we look at that. This is so our spinal cord is no longer that cord, full on cord. However, with all these nerves, this it basically affects the bundle of nerves right at the lower end, so to L3 or below, and we can see it's very similar to that herniated disc, but now instead of affecting the spinal cord itself, we're just affecting that bundle of nerves, that very dense bundle of nerves right down there. And so it could also be caused by a spinal tumor or infection in the area. It can cause bladder or bowel dysfunction, severe progressive weakness of the lower extremities, loss of lower sensation between the legs, buttock, inner thighs, back legs, and in the feet and hands. If you guys remember how our dermatomes look, typically on our chest and kind of higher, it's very kind of lines up with the spine and just kind of goes straight across. There's a little bit of movement, particularly up on the arms and our higher area, C70 and T1. Those areas kind of hits the arms. We'll get down to the lower area, particularly where the quadricline kind of goes. Those nerves kind of spiral around the legs, and our dermatomes kind of follow that. So that's where they could have a weird feeling, like a patch, like part of their leg that kind of follows a spiral pattern down it. Think of quadricline syndrome with that. Next, we'll look at just some of the other things that can come with lower back pain. Sprain, strains of the lower back, the twisting and pulling and proper lifting, all the things that us and EMS do. Hopefully, we're getting better. Biggest treatment, and it's just an injury to either the muscle ligament, one of the ligaments within our spine, or a tendon connecting one of the muscles. We have a ton of back muscles, one of the strongest groups of muscles in there, helps all of our support. But if we lift wrong, we can cause a strain there, whether it's a tendon or muscle itself. And typically bed rest for 24 to 48 hours, analgesics, muscle relaxants, anti-inflammatories. Anti-inflammatories are pretty big too. And move on. Joint disorders. We have arthritis, which is, it's kind of broken down into a few different ones. Typically, what arthritis is in general, it's inflammation of the joints characterized by pain and swelling. Osteoarthritis is chronic degenerative joint disease affecting people older than 50 typically. Onset's gradual, affecting more men or women than men. Usually that kind of all rolls around to postmenopausal, and that lack of having the female steroid or hormone, which really helps regulate a lot of skeletal and muscle growth and use, where men don't have that as bad. They still get low T, and we get low T or low testosterone. We'll also see them have some more osteo issues, to include joint, such as arthritis or osteoporosis, or a couple other ones we can look at. It's why it affects more women than men, and it also results from just wear and tear on the joints in general. If you constantly wear them down, you're going to have worse injuries. Now, there was, I don't remember his name off the top of my head. However, there was the guy who actually won, I believe, the Nobel Prize for, on one hand, he cracked his knuckles every day, and on the other hand, he didn't, and he is a doctor, recorded all his findings, and there was no different outcome on one hand versus the other. So cracking your knuckles does not, as far as that one isolated study, but so far pretty decent because he did it his entire life, show that it causes any type of cracking knuckles doesn't cause arthritis. That's what I was getting at. But wherever that arthritis is at, if it's generally all around, they can just have pain and stiffness in all their joints, or if it's just kind of isolated to certain limbs, we can see that as well in that isolated area. Many times you see it in the knuckles and hands, because that's where we had most of our movement and a ton of our articulation just to get through everyday life, such as you guys taking notes, things like that. So next we have like rheumatoid arthritis. Rheumatoid arthritis is a little bit different. It is a autoimmune dysfunction. It comes with an inflammatory joint disease because pain, swelling, and loss of function. It typically happens in a symmetrical pattern. So if it happens on the right hand, it's going to happen on the left hand. And symptoms include fatigue, occasional fever, and general malaise. And like I said, it's more of an autoimmune disease that attacks the different joints than it is our typical osteoarthritis. Treatments: anti-inflammatory, disease-modifying, anti-rheumatic drugs to slow the process. Some surgery included joint replacement, tendon reconstruction, and symplectomy. Removing the synovial joint type things will help with that. Some other joint, so we have septic arthritis, which results from a direct invasion of the joint by microorganisms. And it's just going to be very swollen and look the same. And it can be whatever type of infection. This looks very cellulitis in nature, but that might have got through the skin down into the joint itself and caused that surgical drainage and irrigation followed by antibiotics. Not a lot we're going to do. Joint disorders. The gout, form of arthritis marked by deposits of uric acid crystals in and around the joint. Acute surrounding tissues appear red hot swollen. Risk factors, joint injury, obesity, heart failure, hypertension, alcohol use, diets rich in meat and seafood. Treatment, anti-inflammatories. Acute episodes usually subside within 24 hours. Usually appears in one joint at a time and associated with an increased risk of kidney stones. Active gout, the surrounding tissues appear hot, red, swollen. Pain is very intense from what I've heard, and it is worsened by light touch. I'm not sure the pathophys beyond that. May remit for long periods of times and reoccur. Chronic gout can lead to gouty arthritis. Risk factors, like I was saying. So there's the gout. Fantastic. Some other ones to look at. We have inflammation of skeletal muscles can result from injury, infection, and autoimmune disease. Myalgia is a muscle pain or pain in multiple muscles resulting from overuse, muscle injury, stress, virus, infection, or autoimmune disorder. So muscle algia pain, inflammatory myopathies. So group of diseases that involve chronic muscle inflammation accompanied by weakness. So we have dermatomyositis, skin rash precedes progressive muscle weakness. Polymyositis causes muscle weakness affecting both sides of the bodies, and myoitis, inflammatory muscle disease characterized by progressive muscle weakness and wasting. Myalgia, no cure for inflammatory myopathies. Dermatomyositis, and polymyositis. Treatment include medications, inflammation, physical therapy, exercise, heat therapy, orthotics, assistive devices, and rest. Treatment for myotitis, physical PT. PT is great. The ones, chronic fatigue syndrome characterized by profound fatigue, not improved by bed rest, marked decline in ability to perform normal functions, worsening follow physical and mental activity, digestive problems, pain, lymph node tenderness, swelling, nice sweats. Cyclical, so alternates between periods of illness and well-being based on history and science. I don't have a ton extra on a couple of these guys. Some of these are just diseases we need to be aware of. So if you have any, take notes, follow up on in class, and I'll try and see if I can find more on that. Bursitis, inflammation of one or more bursae. Bursae are the sacs within a fluid kind of in our joints, and so we'll typically see it many times on the elbow. I have a couple pictures I think coming up. We'll take a look at it, but it can be in any synovial joint where we have a bursae there, and some of the increased risk factors are overuse injury. You'll see it a lot in like pitchers in baseball or just any player in baseball, but particularly pitchers because they're throwing their arm 100 times a game and just it starts getting swollen. It's worse. Other ones, hip injury, spinal disease, leg length inequality, right? Their joint, if their legs, none of our legs are exactly equal, they're pretty close, but some people have a little bit bigger difference there, and because it causes overuse of one joint. Rheumatoid arthritis because it's just getting into the inflaming of the joints. Previous surgery in the area, bone spurs of calcium deposits on our different areas around the joints, and the treatments will be corticosteroids, antibiotics, physical therapy, needle aspiration of bursae fluid, and so they'll get in there and they'll try and drain some of that fluid. So this is an example of bursitis, and so this is inflammation of the fluid sac on a bony tip of the elbow. This is where you'll see it a lot, and the elbow gets all nice and swollen. And what will happen, we have that thin synovial membrane there, and it slowly secretes that lubricating synovial fluid. However, it gets infected somehow or inflamed, and then whether it's just kind of that repeated use, like carpenters, that's a big one, always using a hammer. Wrestlers, volleyball players, particularly wrestlers, Brazilian Jiu-Jitsu, where they're doing a ton of joint manipulation. That'll happen in there a lot. Or refusing to tap because some people are stubborn and never want to tap. Maybe me at one point. and some other systematic issues like rheumatoid arthritis or gout, just infection of the bursa in general. Usually just trying not anti-inflammatories, and if they need to, then they'll do some of the other ones. Vasectomy, so again, get in there and cut it open and draw out what they need. So next, overuse syndromes. So muscle strains, which are slight tears in muscles or tendons. Hamstrings and quads are two of the big ones that typically happens. While we don't necessarily need to know, I don't believe it's fully tested anywhere, but just kind of being well aware of different grades, grade 1 being the lowest, and it's just kind of that weakening, grade 3 being a complete tear. We look in there. So a strain is a stretch, tear, or rip in the muscle belly or tendon. Muscle strain seems to occur at the junction between the muscle's belly and its tendon. So we can kind of see that there. Right in this area, muscle is a soft tissue. Yeah, understand what muscles are. And these injuries are caused by excessive force and tension within the muscle fibers. Tensile forces are produced when the muscles stretch beyond its normal range, causing fibers to tear. We see strains happen in sport, and we'll talk about sprains here in a moment. But usually not warming up first and going straight to sprinting, or even if you haven't lifted in a while and you start lifting, you go really heavy, really fast, and you're not using great kind of form, and you will cause that injury. And part of it is due to because while our muscles do shrink when not being in use because there's such a huge user of energy, there's still a lot of the overall muscle tissue is there. You just need to get bigger again. And so what will happen is, but the bone underneath it and the tendons, the connective tissue there, will have kind of gone back to their previous use. And so when you start using them again and you put all this strain on them, then we will cause this tear in there. And depending on how bad, we can see is at grade 1, 2, and 3 on there. Sprain instead is a stretch, tear, or rip in a ligament or joint caps of ligaments or sheets or bounds of collagen fibers that are connecting two different bones. You can look down here and see many of our joints, particularly in the more ranges of motion and movement that a joint has, typically the more ligaments it has trying to keep it supportive. Our elbow, while it still has quite a lot, is a hinge joint and only moves basically in one direction. And so there's only a certain amount of ligaments there to try and support that, versus our shoulder has all the ligaments, our knee has quite a lot, ankle has quite a lot, right? The more we can move it, the more extra ligaments around to try and support that. And these injuries usually occur when a joint is forced beyond its normal anatomical limits, resulting in stretching, tearing ligaments, joint caps, or both. And because they affect that joint stability during movement, sometimes they'll get a tear in there, they'll try and walk it off. You see this in sports, particularly professional athletes, and then they'll do something else and they'll want to get back into it, whether it's to make money or help the team win or whatever else. But we see it all around, and then they further cause injury and cause a complete tear. Some big ones that we see: ACL, MCL, LCL. We hear those a lot in football. And many times how these happen are ankle sprains and shoulder sprains. Many times what will happen is they'll pivot, they'll go one way and their foot will stop and their that joint will keep moving, and then it'll cause that sprain. If you've ever been lifting heavy out hiking and you don't have good boots, you roll your ankle and it's just moving that motion. It's not by muscle like a strain is. Instead, it's a moving the joint typically out of its normal rotation, usually with some force, whether it's added weight, speed, whatever way. So like speed in the sense of sports, added weight in the sense of out hiking, and it can just cause that joint to move beyond its normal one, and it'll cause a tear in the ligament around there and around that joint, and then now it's extremely unstable. It can cause all types. They're also described in first, second, and third degree grades. Achilles tendon. I believe Kobe had this. My uncle had one of this too, and basically what he said, it felt like a gunshot to the back of his ankle, and all of a sudden he just felt his entire calf muscle curl up into the upper part of his calf. I haven't seen this a ton, but my uncle's description of it sounded brutal. You will see this it can be in sports pretty season ending injury, and many times people have a hard time getting back to where they came from. So our Achilles tendon just kind of runs down the back after attaching to the calf muscles, then it attaches to the calcaneus of our bone. And when there's any type of, so we have tendonitis, which is a swelling of that tendon, then we have degeneration here, and so our inflammation. And when you tear it, that just springs up, and because that's a pretty strong muscle there, it just contracts heavy into the thigh. All right, peripheral nervous syndromes. So we have carpal tunnel syndrome. Always joked about if you haven't seen The Office, which if you haven't, I don't know where you've been in the last 20 years, but seen a lot in office injuries and also other ones that use a ton of like muscle and hand movements. Barbers with scissors or hair stylists that use a lot of scissors. Any type of thing like that can cause some of this carpal tunnel syndrome. Not just typing on keyboards. I think I'm going to get it here soon. But we kind of look at it. It's mainly due to congenital predisposition. Frequent burning, tingling, or itching numbness in the palm and the fingers. Management, diagnosed through test. Some of the treatments it can do is to therapy to control pain, decrease swelling, reduce inflammation, wrist clenching to maintain correct position, wrist position, exercise, physical therapy, and sometimes surgery. Here's a great picture of this. So we have the transverse carpal ligament goes across the carpals or wrist bones, and then that tunnel right there, it swells and causes inflammation on the nerve of the hand. And so as the hand goes up, it becomes numb and pain wherever that transverse carpal ligament is putting pressure on the nerve, and so it can cause pain in a decent part of their hands. Ulnar nerve entrapment. So when we talked about the elbow and why we don't want to move this around, right? Why we splint in place. We can see this nerve coming down in yellow, gets caught and entrapped within the joint, and basically causes numbness, pain in that arm or whatever, any other weird nervous symptoms. And it can be associated with a previous injury or cyst in there. And sometimes it's just due to that. If there's an injury to this elbow, this is why we got to be very careful when we immobilize elbow joints. We don't try to reduce these in the field. If you do, you're wrong. I think I've said this like 4 times now between trauma and here, and they'll figure it out in the field. But we don't are in the hospital. We don't do anything in this field. We try and support you in there. All right, so looking at soft tissue infections, we have fasciitis, inflammation of the strong connective tissue that forms beneath the skin. Big one is necrotizing fasciitis, or the flesh-eating bacteria. Rare but critical, rapidly progressing inflammatory infection of the fascia. We looked at this last semester. Normally, guys found that it can happen within, like, it can start spreading very rapidly within hours. It's a pretty wicked disease. I don't like anything that eats your flesh. Intense pain, fever, chills, diarrhea, vomiting, requires emergent center surgery. So they're going to get in there and they're going to debride. If you guys remember in burns, debriding is where they get in there and they get rid of all the dying and necrotizing tissue. In the case of burns, they're trying to get rid of for sepsis. In this case too, but they're just going to cut out all this. And so they'll have these big open wounds. This actually goes to a burn center many times if it's bad. And because it's much of the same type of surgery, it's treated much like a burn in the sense of they're just trying to clean out these wounds and have them grow back a certain way, and they have to get rid of so much flesh. It's not a burn, but the treatments with it, the burn center is very equipped to deal with, and so that's why many times these go to the burn centers. That's also a mandatory reporting thing typically. Usually we don't find necrotizing fasciitis, or we don't recognize it necessarily as such. You will be getting a call typically by whomever, because it is contagious, your supervisor, and letting you know sometimes if you were exposed to that and they found it afterwards, the hospitals should let us know. It's very rare, but all of a sudden you'll hear about it. So plantar fasciitis, we can see the plantar fascia kind of going up underneath here. It's at tendon, right, or the fascia, right through here. It's not tendon necessarily, it's a fascia, and the fasciitis is just a swelling of there, and then the palmar fascia right here, and so we can get these anytime that gets infected. We have that plantar fasciitis or palmar fasciitis. Soft tissue, more infections. I believe this is some of that necrotizing fasciitis. It's pretty horrible from where I got these, and so you can see where they're needing skin grafts and everything, and why this goes to a burn center. The one I'd seen during my burn center rotations, basically the guy's entire buttocks got eaten away, and it's actually gangrene versus which one of these might be, and they had to go in there and they had to debride it constantly out, and they have to try and heal it all up, and so they can, but it needs to get to the right center and it needs to be dealt with. Otherwise, they will die. We can see here if it gets into their airway, how quickly they can die. Ugh. Gangrene is the same. So the patient I'd seen in the burn center was gangrene and not necrotizing fasciitis, but very similar, and in the sense of how they kind of need that same treatment. Dry gangrene caused by reduction of blood flow through the arteries. Wet gangrene develops complication untreated infected wounds, which one of those kind of looked a bit more like. The tissues appear moist and produce oozing fluid or pus. And management depends on. There's a lot there. We're gonna pain manage these. I'm gonna wear probably a full PPE gown. I don't want this anywhere near me, and maybe throw away my uniform afterwards. That's just me. That's not required. So where we can see here, and typically gangrene does happen around the groin area. So it's some of the things with these. Yeah, it's just you have it all male. It can happen right. It's brutal. It's horrible. It's one of the worst things I've ever seen. I don't ever want to see it again. So things with the dry gangrene, just kind of dry and looks meh. Not a lot with that one. So Peruncia, common skin infection on the lateral folds around the nails caused by injury, nail biting, hanging nail, invasion of bacteria, yeast, or fungus. Pain, redness around the nail, pus-filled blisters, incision, drainage of the infection, nail removal sometimes, antibiotic therapy, warm hand soaks, signs of systematic infection, including red streaks, chills, fever, malaise, joint pain, muscle spasms, all that. Here, there's a picture of it, just in case. And you'll get this weird swelling all around the joints, or the nail beds, and it'll get all swollen up there. Bad enough it needs to get in there, and now it will drain it. And any of these, well, typically not life-threatening. If the infection spreads, now all of a sudden the patient becomes septic, and if they already have any type of conditions, now the weakened immune system, elderly, you think that, and it can cause them to grow. So next, flexor tenosynovitis, and causes eruptions of tendon function in the hand. Signs, symptoms. Remember, there's not a for joints, our tendons have a little bit of blood flow. Our ligaments have next to none. That's why it takes them so long to heal. And there's very, very little blood flow to the tendon or to the ligaments, and only a little bit to the tendons. So that's why, particularly the ligaments, they'll get, and then they'll have to do different types of surgery to try and fix these. And flexor tenosynovitis, because disruption of tendon function in the hand. Fever, chills, canals, cardinal signs, severe pain on a passive range of motion, swollen digits, fingers that are held slightly flexed, swollen, and tenders along the flexor sheath. Management, surgical drainage, antibiotics, splinting, elevated hand. Doctors. This is an example of that. One single finger swollen, pain to percussion, palpation on the flexor tender sheath, sausage digit, thing is huge, held in the passive flexion, just kind of, and if they try and extend it, causes worse pain because there's pain on the tendon on the sheath. All right, so every week we're going to be going over a different type of healthcare. Idea behind this, guys, is to get you guys familiar with what different healthcare professions and different jobs within as paramedics. So ALS Ops, I'm going to be focusing on the paramedic jobs such as TRT, flight, CCT, tactical medicine, all this. And every week, I want you guys to get back to me on basically a paragraph worth that. We're going to get over this more in class. And the idea behind this is twofold. One, it's not non-healthcare profession, but non-pre-hospital. And the idea with this is to how do you understand what your fellow healthcare providers had to do to get there, their background knowledge, as well as if you're ever interested, you get burnt out in the field, you want to progress past wherever you're at. Some of you guys are in more of a career field that you want to go further on the pre-hospital side. Some of you guys are like, this is a decent stepping stone to nursing, RT, NP, doctor, whatever else. And so this is to try and give you guys some both information on one side of what everyone has to go to get there, as well as if you do want to get there, at least you kind of know what you need to do from here. And so at the very end, you guys will pick one of these non-healthcare professions, or sorry, non-pre-hospital professions, and then you also pick one pre-hospital based, whether it's TRT, fire, whatever else, rescue, different types of things you guys look at. And leadership in EMS, I go over a number of these different ones on both sides, and you're gonna pick one of each and write a small report on that, and we're gonna kind of go over it. So with that, first one, start out with lovely nurses. Basically, they're broken down. They have roughly 3 different levels as registered nurses. In the next week or two, we'll go over NPs, and with that a little bit of CRNA stuff, it's a little bit different because it's a promotion up for them, or it's a next step up. So there's basically 3 levels. You have RN, sometimes you'll see it as ASN, which is an associate's in nursing. Then you see BSN, so that are bachelors in nursing, it's bachelor of science in nursing, and then MSN is masters. Usually just has to do with pay, and a lot of the leadership positions require a BSN or an MSN, depending on how high or where they go. Registered nurses must have a nursing license issued by the state in which they worked. There's certain states that have they call it a compact state, where it's a group of states that all have relatively the same requirements. And so if you have a license in one state, you're able to work in a different state. So how traveling nurses are able to travel about rather easily without having to go through the process. California is not like that. California, whether it's nursing, medics, otherwise, never want to be. They have a number of their own extra things, and there's quite a few states that are not compact states. There's more that are not than are, I believe, at this time. But the medics are working on something similar to that, such as go to Arizona. It's super easy to get your Arizona license. You send within your national registry, your active national registry, and they send you a card that same day. Really easy. California takes about 2 months for medics, 3 or 4 months for nurses. It's a pain to try and get licensed there. So they have to go through their nursing program, which we'll go over some of what their actual class is like and what it entails. And then they have to pass their NCLEX. If you haven't heard of NCLEX, you probably will soon. But NCLEX is just similar to our national registry. It's their licensing examination. Usually each state has, many of them have a couple extra things to go through, like backgrounds, things like that. So become a licensed nurse. Individuals must complete an approved nursing program and successfully pass the NCLEX and all that. So ADN or ASN, ADN, BSN, masters. They're trying to move to mostly BSNs at this time at many places. Associate's still easy. One of our instructors in class also has nursing and is currently just got his nursing and is now working on getting the BSN. BSN just has a lot of extra work, much like my bachelor's for paramedic stuff. It's just a lot of extra background stuff, allow you to understand studies more, all this. You don't typically have to do any more clinicals or anything like that. So requirements just to get into ADN, in addition to high school diploma or GED, most ADN require you to have gen ed classes, including biology, anatomy, physiology, chemistry, English, before taking the exam to get into nursing. Some schools will include that in the program. Some of it will say you have to have these prereqs done prior to being accepted. And some want you to do some volunteer. So there's many positions that want to have you a certain amount of healthcare hours. However, working as in EMS or even as a medic bypasses that many times. And things you need to get in, typically GPA range between starting at 2.0 to 3.25, all the way to obviously 4.0, but those would be the minimums. 3 years of math, including geometry, algebra 2. Sometimes they want college algebra in there, many times as well, or you to at least test and get test past it. 3 years of science, biology, and chemistry, 4 years of English. This is all kind of some of the stuff that's seen in there from the high school and the nursing entrance exams. Sometimes there's some BSN programs that you just get into the program from the beginning and it's your 4-year master's and there's an entire track there that they know what you want to get. Other ones will have a ADN to BSN bridge, are basically just adding on to it afterwards, and you just have some. And then there's even some that have an RN to MSN. Many of them is either a ADN to MSN. There might be one or two out there that is a straight, here's a path from 0 to MSN, but most of them at least require you to have your RN. Some of them require you to have your BSN. And much like many master's degrees, some of these MSN programs will have a specialty in there. Some of the MSNs that are out there allow them to do work as an APRN, or so in a couple different APRNs is a nurse practitioner, which you can actually get doctorates when you guys go up to your ICU clinicals in Spring Valley. Lauren's up there, former coworker of mine at Flight, and she has her doctorate as a nurse practitioner. There's different, and so nurse practitioners are interesting. We'll go a lot more into that. They can, in certain states, have independent practice, but they need to talk to a doc, but they work much like a PA, but they don't need to have a doc sign it after a couple of years. Nevada is one of those. Another area is clinical nurse specialist, certified nurse anesthesiast, and certified nurse midwife. These are all advanced care practitioner type levels, and so you'll see some of these have very so just because you hear midwife, they could have a ton more schooling than you. Some of the midwives out there we talked about in OBGYN, a little bit loose with that, but if they're a certified nurse midwife, they have a ton. Masters or doctorate in nurse midwife. They're very knowledgeable. BSN, just like ADN programs, require prospective students to complete certain prerequisite courses in relevant subjects and or entrance exam. So you'll see a ton of those out there. There is bridge programs. Nurses, as general, the nursing boards can be very, much like unions, are very protective of their own, and so paramedics partially they see as a threat unless we stay out in our area. And so when many hospitals try to add paramedics into the hospital scheme, they don't quite know how to do, because there's certain things that medics can do that nurses can't. Really, it's just two different jobs. They have a similar level overall, but they don't intubate, they don't do certain things outside like flight programs, however we do, but they have a lot stronger pharmacological knowledge. Their farm it's phenomenal, particularly if you start seeing they get even better post once they graduate and they're working into like ICU. Those nurses have some of the best farm I've ever seen. Very good. There's also LPNs. LPN is nursing licensed practical nurse. It's almost kind of like a EMTI. They have their own weird scope. We've seen these at the nursing homes. You'll go there. They're nurses, I guess, but they're not RNs. They're LPNs, not, I believe, is a certificate versus RN is at least an associate's. But there's bridge programs that are set up kind of similar, allow you to skip the first semester or two and get in there and start at a later semester. They're just very protective and they don't want to give too much away, even though many times there's many medics I know that could very easily and have easily gone through nursing school and have kind of pushed it. It's not that hard, and they knew a lot of the content already. So these last couple ones, this one in particular is obviously directly quoted. So paramedics are not nurses, but they do have experience treating people in emergency and providing basic patient care. Don't get too sad about this. There's always fun. If you ever work on a flight team or with a nurse on a CCT group or anything like that, it's just two different specialties of knowledge and two different areas of expertise. I said the board is very protective of themselves. So LPN program typically 12 months. They can licensed practical or vocational nurse. Nursing diploma for ADN typically 12 to 36 months, depending on the program you're in. and associates, which is 24 months. So that's a full program versus just going for the. If you already have all the prereqs, then you only need 12 to 36 months, depending on the program. Associates, from start to finish, if you get into a full program, just kind of like ours, you can get your paramedic and then go on and get it, or you can go through a program like this where you go from only having your EMT basic to full on associates in paramedicine up to 24 months. Bachelor's, 48 months typically. Depending on this, if they already have their ADN, many of them are online self-paced courses, and you can get it done in less than a year. Master's, this is in total, not all together, right? So, or this is not added on 66 months. It's kind of where it ends in a DNP, Doctor of Nurse Practice. So they're 84 months. But once again, some people, like Lauren, did it very step by step, got her ADN, then ended up getting her BSN. And then while flying, was able to get into a DNP program and eventually pass. You can go 0 to hero on this and get into a nursing program, get your BSN, then move to that. These two, masters and doctor of nursing, don't. You don't need a master's to get your DNP. Those are just two separate ones. All right. Their scope of practice: LPNs assist RNs and doctors providing basic medical care of patients. They can change bandage, catheters, and IVs. So they can start IVs. They can check vital signs, write reports, give meds. Typically, they can give it under RN's direction and report any changes. Sometimes they give IV meds. Yeah, once under RN. RNs, administrative care. Cool thing about RNs, there's so much to do with it. If you're gonna, I once got told if I didn't want to go into fire, then I should go be an RN, because you can still end up in some of the same pathways that I currently have been, and I promptly ignored that advice because that's how I am, and instead went to go be a medic. They can work anywhere from schools to hospitals, nurses, different parts of hospitals, and get into all types of interesting specialty areas. They have a lot more different job opportunities while not having to completely change your career path or go back for additional schooling. Sometimes you have to go back for additional certs, or maybe a schooling if you're going like the advanced practitioner route, but really it adds a lot of unique opportunities that the paramedic career path currently isn't at this time. It'd be great to see that there. We'll see, maybe. Some of the things they can do: administering monitoring medication, developing care plans, taking vital signs, recognizing abnormalities, caring for wounds performed by basic life support. And because they have so many different specialties, there's so many different things that they can do. You talk to a CVICU nurse, many times the doctor's not in, they'll go ahead and start different beds and then go ahead and let the doc know that they did that. And the doc's like, cool, great, go ahead and chart listed that. Or we'll get some other nurses that call us and say, not my patient. So the list, they're all over the place. The school nurses, which have a very unique area, and it's just they work at clinics everywhere. So that's one interesting thing about nursing, is that there's a lot more. Their career's been around about 100 plus, 120 years or so, versus the paramedics, which is coming on, I think, 50-ish maybe. So they have a lot more background, and there's a lot more of them. So they have a bit more different paths there. And then, so APRNs, we'll get more into this next week, but they have many of the same responsibilities as doctors. As such, they're able to perform complex patient care, make diagnoses, order medications, prescribe medications, not just off of doctor's orders, particularly if it's at a place where they don't necessarily need the doc, even if they don't have independent practice, but many times it's just them walking back, having the doc sign it. But if they have independent practice, and then they're able to do everything by their own, they're able to prescribe it, they have their own DEA number, everything. So they have a ton of different things, and there's a bunch of different ones we'll talk about on the APR inside next week or the following week. Here's what they get paid: CNAs, garbage. CNAs like EMT basic. They can't do much. They can change the beds. Basics can at least do more, but not a ton more. But it's kind of similar. LPNs, 48,000. They probably make a bit more on us. RNs make about 22 grand more starting out with us. And these are, and Nevada they pay them pretty well, particularly Sunrise nurses. HCA pays their staff very well. They just tend to run them hard. So particularly Sunrise. Nurse practitioners start quite a bit higher at a minimum there, and you'll see some other ones that get way up there. Certified nursing midwives, very similar. CRNAs at a minimum of like 180. This is a lot of the starting pay. You'll see them up a quarter half. One of Sunrise's Southern Hills. Yeah, Southern Hills. She started, one of Lauren's friends started there about, I think, 220 something thousand. Sunrise pays as a starting, having her DNP. Works a ton. Nurse instructors, teachers, and post-secondary make a lot more than me currently. All right, guys, that's it. So here is this week's. We'll get on to some stuff next week. Have a great day. If you guys have any questions throughout this entire lecture, go ahead and send me, write it down, and we'll go over it in class. Have a great day.